Okay, so welcome to week 4 class meeting. We're covering chapter 11 E&Ms today. We're going to jump into it and highlight some of the prime points that I need you guys, or just to make sure that y'all understand going forward with E&Ms. Please excuse me, I have been really sick this past weekend, and I'm still having coughing fits, so I have a cough drop in my mouth. Just bear with me on that. All right, so like I said, we're going to be covering E&M for like a week and a half. Your exam is going to be next Monday, not this coming Monday, the one after. Okay, so again, we're going to be in E&M for a minute. Next Thursday Zoom, we're going to get deeper into it. Like I said, today, I'm going to highlight some really important points that y'all need to know from jump so y'all can move forward with it. Some stuff that y'all have already looked at in the readings from yesterday and today, if you've done that so far. Y'all are doing really great. Y'all did great on the modifiers exam, most of y'all. If there's anybody, if y'all have any questions about the modifiers, please get with me. But the exams look really good. I felt like y'all had a really good grasp on it. So if I'm wrong about that, y'all please get with me so we can get you sorted out, okay? All right, so I'm going to share my screen and we're going to look at the first few slides on the chapter 11 PowerPoint and discuss that a little bit. And like I said, that slide presentation is 156 slides. A lot of information in this chapter. It's really big, okay? But it's not super complicated stuff, y'all. So it's not anything that's going to give y'all trouble. It's just a lot of information to get through. That's all. All right. So let me Can y'all see the presentation? All right, so chapter 11. All right. So your job as a coder, with coding procedures, diagnosis, anything, is to code what is documented in the medical record. Y'all have heard me say, and I'm sure Patricia is tired of hearing it by now, we don't code what we don't know, right? We code what is documented, what's in black and white for us to code. We do not guess. If we don't know about something, we have to verify it, okay? Our job is to code what is documented in the medical record. We've got to be accurate. That being inaccurate is bad for business. It is bad for our patients. It is bad for our career, okay? It's very important to be as accurate as possible with your coding. I can't stress that enough. Very important. Getting the wrong payments if you code incorrectly, not getting paid if you code incorrectly, things like that that'll cost your provider money. You make a bad enough snafu or enough of them, you will lose your job. Okay. One of the things that's looked at about coders is your accuracy. Okay. You got to be on point. Paying attention to what you're reading is the big thing. That's the big thing. Just pay attention to what you're reading. Okay. As a coder, you want to optimize, not maximize. And what I mean by that, optimization, you're trying to get the most out of. So as an example of that, if I'm coding and I get a chart from the office and they used let's say a low level new patient visit, it was a 9921 or 203, okay? But as a coder, I'm looking at this, I'm reading over the patient records, and I see that this patient has diabetes, hypertension, foot issues, you know, due to diabetes, all this different stuff, neuropathy. Well, that's going to require some pretty heavy duty counseling, a lot of discussion with the doctor and the nurse and all that stuff. You know, that's high in the medical. I'm having a brain fart, y'all.
Hey, Miss Brandy, sorry I'm late.
It's all good, Martinique. How you doing? I'm having a
Work.
brain. The word I'm looking for. It's high problem list. Okay, that's a lot of problems. I can bump that up from a 99203 to a 99204 and maximize or optimize my code. Okay. Now, what they mean by maximizing is to increase or make as great as possible. I'm not looking for any reason to bump it up all the way to a 99205, which would be the highest level and which would get paid the most, would get reimbursed the most for that code. But I'm not trying to do that. I'm not trying to just get as much as I can, right? But I have reason, I have justification for lifting it up to a 99204. So you want to optimize, don't maximize. Okay. Don't ever increase it. Make sure that the provider's getting all the reimbursement they're supposed to get, what they should get. Okay. But you're not going to use a higher level code just to get a bigger payback. That's called fraud. We don't do that. Okay. And again, accurately report documented services. If it's not documented, it did not happen. We do not guess and we don't document, we don't code what we don't know. A crime. Coding for services not provided is a crime. Like I said, yo, that's fraud. And believe it or not, you can go to jail. It's insurance fraud. And if you're filing to Medicare, guess what? That's a federal entity that you just tried to commit fraud with. So, not the thing to do, right? Not the thing to do. And it's really easy for them to know when somebody is doing that on purpose. Okay. Everybody's going to make mistakes in their coding here and there. What they're talking about as far as fraud, they can recognize when every patient they see is a 99215. You know, the highest level, everything. Every patient's that. There are offices that run that way. I've worked for providers when I billed a 99202 or 203. They came back and said, "Why did you do that? You need to build a higher E&M." I said, "Well, show me documentation that supports the higher E&M and I'll bill it. Otherwise, I'm not going to jail for you."
Isn't that when they want you recoded from if it's a level 1 to a level 4?
Actually, the level, yeah, you got your different levels. We get deeper into that in a minute. But
oh, I'm sorry.
You're good. You're good. You have different levels from 99, you know, your 201s, 211s, which actually are not used anymore as of January 2001. We now start at 202 and 212. Whether it's a new patient or, you know, established. But the higher level you go up, the more money it's worth. Okay. So yeah, you will find people out there that do that. Don't get yourself mixed up in that. If you're working for a provider that wants you to do that, quit and go elsewhere ASAP. Okay. Because they will get audited. Medicare audits people all the time for no good reason. People that they don't suspect of fraud, they just come in and audit just on the off chance to find a penny. And y'all think I'm kidding? I'm not. Medicare will actually come back and take back money that they paid 2 years ago. They'll snatch it from your account before you even know it. And then send you a letter as to why they took your money. And guess what? It's 2 years ago. So you're past timely filing. So there's nothing you can do about it. You can't fight to get that money back. So, accurate coding. Yeah, billing for services never rendered. Not the thing to do. Okay. So, evaluation and management section. This is going to be where you report all your physician's services, the things that the physicians do. Again, procedures, things that are done to your patients. E&M is going to be your office visits, consultations, inpatient and outpatient services at a hospital. All right. Subsections by type of service, which basically means in our CPT manual, y'all have recognized, I'm sure, that it's broken up by body system and then services accordingly. Types of service: office, hospital, and consultations. All right. Like I said, anything that takes place in the doctor's office, a clinic, is going to be your like outpatient services, office visits, psychiatric therapy, anything like that, counseling is going to go under that consults category. In your hospital services, anything that happens at the hospital, and that could be outpatient or inpatient. And there is a huge difference between outpatient and inpatient. We're going to talk a little bit more about that in a few minutes too. All right, so the 3 factors of E&M codes, how you're going to decide or start to decide on your E&M codes: place of service, type of service, and patient status. Y'all hear me talk about coding is basically the who, what, when, where, and why of the medical chart, right? It's going to give us all that information. So our E&M codes are going to tell us place of service, type of service, and the patient status. The higher level code we use, the more high risk that patient is, the more time consuming that visit was, the more that went into that service, the services that were rendered. Right, your place of service explains the setting of the service, which could be office, emergency room, nursing home, urgent care. Y'all know everywhere medical services are provided. These days, it can also be in the patient's home. Telehealth visits are very common now. There are E&M codes for those. Your physicians provide many types of services and procedures, everything from shots, examinations, small surgical procedures in the office, things like that. Office visits, admissions to the hospital, consults, prolonged services. That's more your management. Continued care, long-term care or long-term management of a certain disease or condition. Patient status. 4 status types. You have your new patient, our established patient, outpatient, and inpatient. Okay, so let's break this down a little bit. Do y'all know what the requirements for a new patient are? What qualifies someone as a new patient?
Someone who hasn't been seen before in office?
In how many years? How many?
3.
3.
3 years. Exactly. Now, sometimes you got to watch, because the way that's worded is it's a patient who has not been seen by the same doctor or a different doctor in the same group. So who knows what a group is?
More than one doctor in the office.
Right, but here's the rub on that. That group could extend far outside of one office. Like take Christus group. All right, in Alexandria, Christus has Cabrini Hospital, the Incarnate Word Community Clinic, the Cabrini Cancer Center, Christus Community. There's at least 5 or 6 different urgent care and community clinics that they have just in Alexandria and Pineville. And I know that they stretch all the way up to here in Shreveport. They have stuff up here. Christus. That's a huge group. And what's weird about that, y'all, I used to work for them, so I got the inside. Every single facility that they are involved with runs off of the same tax ID. And I could spit it to you. I could spit it out. I've written that number and typed that number so much I could tell y'all what it is. But all of Cabrini runs off of, or the Christus St. Francis Cabrini group, every clinic they have in the state of Louisiana is off of one tax ID. Okay. Now, under a group, you may have other separated groups. Okay. They may have a group for just their hospitalists that work at Cabrini Hospital. They may have a group for just their doctors that work at their Incarnate Word charity clinic. Okay. Now I know for a fact that Cabrini Hospital makes their attending doctors work rounds at the charity clinic. That's part of their contract. They have to work a certain amount of hours in that clinic every month to keep their job. So, hey, we got a visitor. Hey, Miss Jessica.
Hello, how you doing?
Doing real good. Let me
Hi, everybody.
let me wrap up the sentence I was in the middle of there, and then I'll introduce you to the class. Okay, so Christus all runs under that one tax ID. They have different groups that branch out. Okay, so say you see Dr. Smith at Christus Community Clinic in December of 2020. Okay, and that was the last time you think you saw anybody at Christus. You go to Christus Hospital 2 years later, 2.5 years later, get some services done by Dr. Jones. Okay, are you if they are under the same group, are you considered new patient or established patient? It's been 2.5 years. They're in the same group. Are we a new patient or are we still an established patient?
Established.
Established.
Established patient.
Established patient, that's right, because it's been less than 3 years, right? And they're in the same group. Now, wait the 3 years, and then you would be considered a new patient if you went to another doctor's office that was associated with Christus group. If you step anywhere outside of that group, you're going to be considered a new patient. But like I said, these groups are huge and they encompass many different facilities, different clinics and urgent cares. And they all swap data and information. And that goes along with being an established patient. Your data is already in that system. That's why it costs a little bit more for those new patient visits, because there's more work that goes into putting you into the system, getting all your data, your medical history, your charts, everything brought in and put into their system where their doctors can see it all, right? Is that kind of clear? All right, so I'm going to go ahead and introduce our visitor. This is our new Miss April. Y'all remember Miss April? She used to pop in. She was our director of education. And a few months ago, she got a wonderful promotion. She is now, over the entire online campus. And this is Miss Jessica Washington. And she started just a couple of weeks ago, but she is our new DOE, or Director of Education for Online Campus.
Hello, everyone. At any time, if y'all have any questions, I know in the roster for e-learning, my email is in there. Y'all could email me at any time. Y'all could also call the office. I am available to speak with you. You might see emails, the same thing Miss April does, with congratulating you on passing a test, or if I'm looking at an assignment and I love what you did, you'll see emails. So you're not gonna just see if you're doing something bad. I like to encourage and promote as well. And I look forward to speaking with you in the future.
Awesome. Thank you so much, Miss Jessica. We really appreciate you coming in.
You're welcome. You're doing a great job, Miss Brandy.
Thank you so much. All right, guys, I'm gonna jump back into our presentation. All right, so that's the difference between new and established. And like I said, there is a reimbursement difference there. So we want to be as accurate as possible. As accurate as possible with our coding and recognize when we have a new patient or we have an established patient. All right, so outpatient and inpatient. And this is going to refer mainly to hospital services, whether it's outpatient or inpatient, but it's very, very important differentiation, because when someone is admitted to the hospital, the rules for coding really change a lot. Inpatient coding is a lot different than a lot of what we do here. What we teach y'all is primarily physician services. We dip into hospital stuff, but not real big, because it's pretty specialized. But so you got to know, and even when you're coding for a doctor that's not in a hospital or affiliated with a hospital, if they have patients that get admitted and things like that, you're going to need to know their status when it comes to talking to insurance companies about claims, especially if they end up having a surgery or something and the insurance company is trying to claim that your services were inside of a global period, because the patient had surgery or whatnot, or they were in the hospital. I've had insurance companies tell me that. I was like, oh, the patient was in the hospital. They were inpatient on this date of service. And I'm like, no, they weren't. They were admitted on such and such a date, which was after my date of service. So no, it does not apply. But you have to be aware of whether the patient is inpatient or outpatient if you need to argue that with insurance. Okay. I have a little bitty spider on my web. And I hate spiders, so I'm trying to kill it with my pencil. It's not working. Okay. All right, so Office and other outpatient code guidelines. These are just some of the latest code updates that they had. And like we talked about just a few minutes ago, as of January 2021, the last major thing they updated was they took out the use of the 99201s and the 99211s. They're not being used very much anymore. So they updated, and that happens. And that's why I tell y'all, don't stress yourselves out about memorizing codes, because they're going to change. They're going to go in and out of use and things like that. All right, see, 99201 deleted. Code selection based on medical decision-making and total time only. And they kind of changed the way they wanted you to figure out which level of E&M you needed. It used to be you would add up all the time you spent with a patient. You spent so much time taking their information, so much time taking their stats, so much time getting their medical history, so much time in the exam room, so much time setting their next appointment. And you would add all that up, and that's how you would make those decisions. Okay, make that determination as to which level code you want to use. All right, now they're focusing more the elements affecting the management of the condition. And basically what that means is that instead of focusing so much on all these individual tasks that people are doing, instead of I'm going to call it micromanaging, because it's kind of what it was. micromanaging all these individual tasks. Let's look at the disease as a whole, the patient as a whole, and see what kind of time and effort and training and things like that go into managing what their condition is. Okay, so that's what they kind of mean by that. Which problems were addressed, what problems, what kind of data was reviewed, and the risk. The more serious a condition is, the higher level of risk it's going to be. Okay, if they are in end-stage renal failure, end-stage renal disease, that's some pretty heavy duty diagnosis, heavy duty medical decision making there. All right, you do still look for your office visits and whatnot. You do still look at time. Time is still a factor. But it's more of an overall than each individual task. Like for an E&M code, like a 99202, there's a certain time frame that goes along with that. And we'll look at that in our CPT manual in a minute. Okay, and here they just list out all the different tasks. And guys, this is the same presentation that is on e-learning in your PowerPoints. I'm using the exact same presentation as what the book followed. It just happened to be the information that I wanted to go over with y'all today. So if y'all want to find this here for notes, it's in the PowerPoint. All right, documentation of counseling and or coordination of care not required. And the reason for that is because in a lot of different procedures and even some diagnosis, there's a certain amount of time that's already taken into consideration. That's already added in there. Like it's obvious and well known that said procedure or said counseling about whatever drug or whatever procedure is going to take at least X amount of time. So that's already considered in. And for an example of that, you remember when I was talking a lot about monkeypox vaccine and how there had to be an administration code that you put in with that. For an adult, it was one number, but for a child, it was another CPT code because it included a counseling session with it because it was for a person under age 18, which meant the doctor is required to counsel with the patient's parent or guardian. Okay, so the time for that is automatically included in that code. All right, so we have already talked about new patient. They just go into a little bit more detail about that. All right, so a little bit about outpatient and inpatient. It sounds real simple. Outpatient, one who has not been formally admitted to a healthcare facility. And this is primarily going to be a hospital. Sometimes skilled nursing facilities will qualify for this. But like I said, I have gotten claims where payment came down. It came down to not only the day that they were admitted, but also the time. Like what time was the patient admitted? Like really? Are we getting down to the nitty gritty that deep? But yes, they are, and they do. So that time and date of admittance has got to be documented everywhere. Okay. Example, patient received services at clinic at same day surgery center. That's outpatient because they are not admitted to the hospital. Okay, patient admitted to observation status. And that is when a person goes to the ER, they may not necessarily want to keep them in outpatient status and not necessarily admit them yet. They're going to have them stay in the ER for however long, maybe 24 hours, or they may want to keep them for 2 or 3 days, see if a certain treatment or something works. If they're trying to rule out a diagnosis, they may put them in observation status between outpatient and inpatient. There may be an observation in the middle somewhere. So that's something to look out for. Inpatient, one who has been formally admitted to a healthcare facility. Again, hospital or nursing facility. Okay, in the event that a person is admitted to the hospital, the attending physician is the person who is going to dictate their chart, take care of them while they're in the hospital. Your attending physicians attend to your patients that are in the hospital, that are admitted to the hospital, that are in inpatient status in the hospital. They make rounds every morning and they see all the patients in their particular, on their floor or involved in their specialty, okay? Now, they may get called to see a patient on a different floor if a patient is having multiple problems, or if, who knows? All kind of stuff goes on, y'all. You never know what goes on. But that's what your attending physicians are. And whenever you have a patient that is in inpatient status, it is the attending physician's notes that your insurance companies are going to want. Okay? So remember that. Inpatient status, attending physician's notes. And they will require it like every time. Every time. I have actually done billing for hospitalists, for Cabrini, as it were. And they want those dang notes. And sometimes the doctors are really late getting them in. So sometimes you have to be on a doctor's actually calling and leaving a message with their service. Right. So they are going to document your admission orders, your history and physical or H&P, your requests or consultations. Okay. And that's if they need to call in another doctor from another specialty. All right. To get a consult on this patient. All right. Your levels of E&M service are going to be based on the nature of the presenting problem. That's going to be your foundation. Your skill required to provide the service. Time spent if 50% of the total time is counseling or coordination of care. Okay, so I'll get that. Time spent's only in there if it's 50% of the total time is counseling or coordination of care. The level of knowledge necessary to treat the patient, okay? The more advanced a diagnosis they have, the more likely they're gonna want to see notes from the doctor, him or herself, versus the nurse practitioner or the doctor's assistant, okay? Effort required or assumed. Responsibility required. E&M levels are divided based on key components and contributory factors. Every encounter contains varying amounts of key components and contributing factors. Okay, and that is where I'm going to stop on the presentation part of this, because there's a couple other things I want to show y'all, and I don't want to go too far into chapter 11, because like I said, we're going to be in there for a week and a half, and next week's Zoom is going to be continuing on in chapter 11. But there are a couple of things I want to show y'all first. The first one, you remember when I told you guys that the coding that y'all are going to see in the workplace is not quite like what we do here. And I talked to y'all about a super bill, and I said that, a lot of the times, the way my first job worked, I was a billing specialist, and we had coders. And we worked as a team. There was about 4 or 5 of us. There was a coder, a biller, a payment poster. And then sometimes, if it was a big enough clinic or the account was big enough or there was an issue with it or something like that, we would have additional people that specialized in one type of billing, like Medicare specifically or Medicaid specifically. I did everything but Medicare for that particular job. We actually had, for this particular clinic that I'm talking about, the coder handled the Medicare billing. just because she was the most experienced with Medicare and the best at it. She's also coded surgeries. So when I tell you, and she'd been doing this for like 25 years, 8 years ago. So she knew her stuff. Like, hard to find a more knowledgeable coder out there than this particular lady. Unfortunately, she and I got along like oil and water, personality wise, but she knew her stuff coding. But so she also handled the Medicare outstanding charges for them. But the way it would roll in, we were an outsourced billing company, right? So they would capture their charges and everything in the office, send it to us, and we would handle it from there, handle it on what we call the back end. So the way that they do that is when they would see a patient in office. Okay, I hear you. When they would see a patient in office, they would have a super bill that they would fill out, and then they would send that super bill to us. Windows. So they would, as they're seeing a patient, they would have this super bill. The nurse or nurse practitioner or nurse's assistant, whoever in the office handled that super bill, would fill it out and then send it to our coder. And as y'all can see, can y'all see it, by the way? You'll see this document? Okay. This is it's basically a template. It's a super bill template for a family planning doctor's office, okay? So what a super bill is, it is basically a checklist. And it can look like this, or it can look a little bit different. It depends on the company and the office and all that. But what it is it's a basic list of the services and procedures, and diagnosis too, drugs too, all the things that they do the most. They put those codes on one sheet. It's called a super bill. And every patient that comes in, for every visit, they have a sheet. And everything that's done for that patient is put on that sheet. And if it's not listed in this list, there is a section down at the bottom where you can write it in. For the ones that I would get sometimes, they would flip the super bill over and just write in what they needed to, if they thought something needed to be written in. But as y'all can see, look how it's laid out. New client, E&M. Established client, E&M. Education and counseling. And they have the 5 codes there. And then they have the time right next to it. Okay. So, and it wouldn't be odd to get a super bill with, say, 99202 checked off, and then scratched out and initialed, and then 99204 or something, a higher level, put in later. That happens because sometimes they end up spending more time with the patient than they thought they were going to, or they jumped the gun filling out their paperwork, whatever the case may be. So a lot of the times, as a coder, you're getting super bills. Most of the coding is already done for you. You're there to verify, and what they call optimize. Make sure that your provider is getting maximum reimbursement, and make sure that the coding is accurate, okay? Because remember, the person that's filling this out, probably not a coder. So you have a super bill and you have medical records. And basically what you do is you consolidate the two. You make sure they match. Nobody left anything off. Whatever modifiers need to be added are added, because most of the time that's not going to be on a super bill. Things about modifiers and stuff, usually not on the super bill. That has to come from the coder. Okay, we need to know, and we need to add a modifier. Sometimes if you have somebody that's experienced enough on the other end, your modifiers are there. Everything you need is there. But you don't always have that. You don't always know who's filling out this paperwork on the other side. So, but this is what a super bill looks like. And again, it's a basic, this bug is driving me crazy. But sorry, y'all. I hate bugs. But again, and look, They have different diagnosis codes that they commonly use, different drugs and supplies that they commonly give out, testing on here, radiology for certain things that they do, additional ICD-10 codes for screenings that they do on occasion. Everything's right there for you. Everything's right there for you. Procedures, labs, everything. And look, complication management, complication ICD-10 code, additional codes, procedure codes, supply codes. It's all right there. Right there, okay? And then generally they will have the doctor clinician sign off on it after it's filled out and before they turn it into the coder. Okay? But I wanted y'all to get an idea of what a super bill looked like, because that is the general format for most of them. Okay, and some of y'all may have even seen these when you've gone into the doctor's office. They may have made you fill out the top or whatever, something like that. Shakira's shaking her head. You know, sometimes they do that. So that's not uncommon. That's not uncommon. All right. So I think that is it. The main thing I want to walk away with today, y'all, is that we have a clear understanding of what our E&M codes are there for. Evaluation and management, office visits, consults, those kind of stuff. And the difference between new patient and established patient. That's the main thing. That's the two biggest things. That is where, believe it or not, that is where 90% of the mistakes are made, is in whether it was a new patient or established patient. That's it. That's the mistake I see the most when we're going through this material, is that mix up. That's all. The rest of it, y'all pretty much catch on to pretty good. But that's a major one, and it's a very important one. So that's why I wanted to kind of harp on that today. But that's all I got for you, ladies. If y'all do y'all have any questions or concerns for me at this time?
I have questions.
Can I talk to you once everybody leaves?
Okay, no problem. What you got, Aaron?
So when are say I graduate on the 7th, right? That's my last day.
Yeah,
So when's then the graduation from that point?
not till spring.
When's spring?
Everybody who has graduated from June of this year, because that's when our last graduation was, June 10th. So everybody who's graduated since then is having to wait until the spring of 2023 because they're not having a winter graduation ceremony. And we
So
don't,
is that like around April?
hopefully it's before then. Dear God, I hope it's before then. 'Cause
Okay, because I give birth in April. So
well, I hope it is before then. But we usually have one June and December. So hopefully we're not waiting all the way till April and then having another one during the summer. What I think she was trying to do for this year, since we had to have this one in the spring because the venue was completely booked in December, we just couldn't get it. I think they're shooting for February, early March, and then having another one in like August or like early. Instead of winter, it'll be fall next year. But that won't apply for most of y'all, unfortunately. Most of y'all, majority of y'all sitting in this room right now, will be spring graduation of 2023.
Okay, I have one more question.
Which guy?
So Unitech is paying for the one time to take the NCCT test. When and how do we schedule that? Who do I need to contact? I can't remember what you told me.
Franny Hoffman.
Okay.
Franny Hoffman's going to be your contact for that. I will generally, most of the people who've already finished, I've been doing it like the day before or the morning of the last day. I send you a like kind of like a checklist of, hey, you have an exit session to do with your financial aid person. Don't forget to get with career services. Get with Franny to schedule your certification exam. And I have her email address on there. But I'll I'll put it somewhere in e-learning, Erin, and I'll send it to you. If you want to go ahead and contact her now, if you think you're ready, then do your things.
Oh, I better
Can I
be.
get that as well?
Who's that?
Me? Can I get it as well? Because I finished on the 9th.
Yes, ma'am, you do. Yes, ma'am, you do. Yes.
Thank you.
Yeah, Erin, you finish on Monday, and Martinique, you finish on Wednesday. So this is both of y'all's
Woo!
last Zoom. And Tiffany.
Oh,
It's Tiffany's too, but I
I'm
don't
gonna
think David-
cry.
why we
Jennifer-
didn't get our name on the board?
Cause I've been sick this week.
Oh, I'm sorry.
It's all
I
right.
was just playing
No.
on Miss Brandy.
Yo, I have had so many of y'all finishing, and with the 8 new ones I've had, and then the baby being sick for 2 weeks, and then like I said, Friday night, the sickness hit me like a Mack truck. And when I say hit me like a Mack truck,
Yeah, the flu is
No.
going around real bad.
I had the flu and tonsillitis. When I tell y'all that I lost 7 pounds in 36 hours because I could not keep nothing down, not water, not medicine, not nothing. I could not swallow. I could not breathe. I have coughed so much in the last week that I have damaged my ribs. I can't even take a whole breath right now. So as far as the cute congratulations graphics that I was doing, I'm gonna try to pick that back up. But things have just been nuts. Things have just been crazy. So just bear with me. But send me your headshots so I can do that. Martinique,
Okay.
Erin, Tiffany, if you're watching, send me your headshots so I can do that. And let's see. Yeah, Brianna and Jennifer. Jennifer usually always comes to Zoom. She finished yesterday. Brianna finished yesterday.
Why you did it? You broke it.
Okay. And then we have,
Look, you broke it.
which is kind of exciting, all of y'all that are coming out, that are graduating, are all in the same group. Like I've told y'all I have 2 groups of students. Y'all have all been in the same group. So that group is like emptying out on me. I have my first graduates from the second group on the 14th, and that's going to be Courtney and Priscilla. Courtney Kramer and Priscilla. So, yay. And then I got 2 more of y'all finishing before Thanksgiving.
Do I finish in February?
You are,
I forgot.
I think, February 13th.
Oh.
February 13th. Anybody else want to know their finish dates while we're sitting here? Because I got them all right in front of me.
I would like to know.
Everybody.
All right, I'm leaving.
Bye,
Bye, ladies.
Patricia. Keep me posted.
I will.
Hey, Phil, come get your applesauce.
All right, let's see.
Lisa,
All right, my 4 students, like Quandanisha,
Lisa.
I just
Yeah.
got you from Peggy. I
You
have
want
not
pudding?
been given your graduation date yet.
Get your snack.
I'm sorry.
I want some pudding.
But
Oh,
I'll
I'm
get it.
sorry. Y'all can hear me. I'm at work. I have a behavior client, and she be trying to go outside. So I got to bribe her back in the house.
Oh yeah, I feel you.
Shut the door.
We all been there.
Yeah, I'm always at work. I'm so ready,
I
Lord.
know, sister.
Miss Brandy, you know, I texted you earlier and was like, look, I get off at 10 o'clock. My assignments and my other exam will be finished. Bear with me.
I know you'll get it to me. I ain't worried about you.
Yeah. That's one thing. When I tell you I'm making it up, when you open it, when you reopen it, I get it out the way because, man, this is my life, Lord.
And y'all, sometimes that's why I say if y'all communicate with me, I will work with y'all around everything and anything y'all need me to get y'all through this program. All it takes is
Color.
communication. Like Martinique has worked 2 jobs and been on the road since she began this program, pretty much. Like, do y'all know how much communication it has taken this poor girl to get all of her stuff in? But she has done it, y'all. She has done it. It is doable. And I have I don't think there was ever an instance where she called or texted or whatever. It was like, hey, I'm having issues with this, or can you reopen that? And I said, no, I can't help you today. I'm not going to do that.
Right. I know I pitched you a lot from personal text messages to on the board. But I
Okay.
must say, as an instructor, you do look out big time.
I try. I really do try. And like, y'all, I'm human. I'm human.
Okay, wait.
Well, you
I
kept
gotta
me
fix
from,
it.
you
Wait.
kept me from quitting the very first day.
The first
I wanted to
day-
quit. I was
Right.
like, I'm out on this.
the first day, Aaron was like, this ain't for me. This ain't for me at all. And I was like, hold on. Give it
I was
a
like, can I, cancel everything? Will they, take my, Pell Grant or money back, whatever?
Yeah, yeah. And I told you to give it a chance. Just give it a chance. It is
I wanted to
overwhelming
cry
when you
that day.
start. It's overwhelming at first, especially if you've not gone to school online before. It can be really overwhelming because it's a new way of learning and it's all new information that you may have no experience with whatsoever. So yeah, I get that it could be overwhelming. It overwhelmed me too when I started working in this field.
Be good, okay?
But
Color.
you just gotta stick with it,
Go
y'all.
get your brush.
Stick it out. That's it. But okay, so Quandanisha, I do not have your start date. Anybody else want their start date or their finish date? Not their
Bronny, yeah, I do, Miss Brandy.
Quandanisha, girl, February 13th too.
Put it in the trash.
You and Shakira started on the same day. Y'all started together. So y'all will finish together. So February 13th. Who else is here? Aaron, you well aware when you finish.
Yeah,
Latasha, do I have Latasha's yet?
but I just want to stay. I want to stay in school. I don't want to finish yet.
You're always welcome to come back to Zooms. Julia popped in for a couple of weeks there, steady. So, and I'm always a text message away if you need me.
Oh, I'll be texting you.
Latasha is one of my newest students, y'all. It's Latasha. And her graduation date is July 5th of 2020.
That's wild.
Yeah, like I said, she just started like a couple weeks ago. Brand new. But she's coming to Zoom and
It's gonna fly by.
It's gonna fly by. Take our word
Yeah.
for it. Take our word for it. It's gonna fly by.
Okay, I'm here for it.
That's it, and you're killing it on your assignments. You're showing up for Zoom, and that's all we can ask for. So y'all are on your way, ladies.
I can't believe this is the last Zoom.
I know.
I know, right?
That's not. I'll be back.
It really it throws it in perspective for me that Aaron is
now.
finishing. Like all my first graduates, like I'm seeing it, but for Aaron, that conversation that we had the day she started, I went to a funeral that morning. I was out of town.
Oh yeah, you were
And I was
driving.
in my car leaving the funeral. It was my great uncle, my Uncle Toodles. But I was leaving Texas, coming back home, and my new student Aaron was calling. I was in the car, had the baby in the back of the car. We're all, been out of town for 2 days, and here I am on 610. I don't know if y'all know 610 in Houston, what that is, but it's a circular interstate that goes all the way around the city of Houston, and you either go 70, 75 on there, or you're gonna get blown off the road. And that is my
I heard they speed out there.
girl. Speed ain't the word. You better
My mama
go.
recently moved to Dallas, and she
You
was
better
like,
drive. You better
"Yeah,
drive.
she
like
don't
you
drive
mean
fast
it.
at all."
Yeah, they crucial in
But
Houston.
she be calling me like, "I'm so scared. I'm on the highway, and they just
Oh,
zooming
Lord.
past." I'm
Tell
like,
her if
"You
she's
in a
scared, she don't need to
Charger,
be on the highway over there.
right?" I'm like, "But
Can't
you
be
got a new
scared.
Charger, so why push it? Go."
But I really like to drive.
No,
I really
Lisa.
like to drive fast. So getting on them interstate systems in Houston, that's my jam. Okay. Zoom, zoom. Mama like to drive. But there I am with Aaron, and I'm driving on 610, and I'm like, it's okay. Just give it a chance. It's all right. All over the place. So that I remember that really clearly for some reason. So it resonates with me that that went by so quickly. That went by
Right.
so fast. And she's finishing next Monday. Told you.
Yeah, but I mean, I'll be calling you because after I found out that you used to live in Alexandria, which is, where I'm.
Which I will be down there this weekend.
Oh, you will?
Yeah.
What you coming down for?
I have me and my husband own a duplex down there.
Oh yeah, you told me in Pineville.
And I lost one of my little tenants is getting married. That's, like kind of like almost like I take care of y'all. The two little guys that I rented my little apartments. I have a little they're like 1 bedroom, 1 bathroom apartments. There's two of them, little duplex. And I've had the one little guy in there, the same guy in there for like 5 years, Laramie, and I love him. And poor Laramie, his house had burnt down, and I had listed my apartment that morning. Like his house burnt down like 4 or 5 in the morning, and at like 10 o'clock I
Wow.
put my apartment up for rent. And he messaged me like directly, and he was like, I need a place like today. And I was like, this ain't supposed to be ready till 2 weeks from now. But God brings people into your life for a reason. And my other tenant wasn't even moved all the way out yet. And I got with my other tenant, and between me and him, we got Laramie in there that day. We got him in there that day, so he didn't have to go one day without a roof over his head. And he has been with me for 5
Hey,
years. And
go
he's been
get
awesome.
your water.
But I have another little guy who's getting married, and his girlfriend is in school in Baton Rouge, and she's going
No,
to
ma'am.
school. So he's moving to Baton Rouge to be with his fiance. So
Come
we're
on.
really happy for him, and he was a great little tenant too.
No, come on.
But he's, our apartments are
um,
great for starters, for single folk, but eventually everybody's got to move on and move up, So we're happy to be that stepping stone. There's a lot of places that won't rent to you unless you have rental history. And we were more than happy to give him his first rental history, because it's hard to get a place sometimes if you don't have that. So he was,
Right.
he was a great little tenant. So we're going to give him a great reference and for his next place.
Email me the address to your little
Apartment?
duplex thing. Yeah, apartment. I might be interested. It would be me and my daughter.
It'll be on Facebook tonight. I'm posting it to Facebook tonight.
Okay.
We'll talk about it.
Okay.
We'll talk about it. But, all right, y'all. Well, if y'all don't have anything else for me, that's all I got for y'all for this week. Thank y'all for your time as always. Love talking to y'all. Y'all make my day.
Bye, everybody, for the last Zoom.
Bye, Erin.
Bye.
Congratulations.
Thank you.
And Martinique. Because this is her last one too. Bye, sister. I know.
But what I wanted to ask was, do we get another report card or our grade pointer or
Progress
something?
report.
Yeah.
I don't think they've sent me the progress report stuff for October yet, but I'll have your grade the day after you're done.
Okay, and also to do the NCCT prep, is that optional or that is what we need to be qualified?
Okay, so the exam, like the purpose for taking the course is to take that exam, to get that certification.
Okay.
But it is optional. It's not a requirement to finish the course. You finish the course, you're done with the course, and you can always say, I completed this. I did that.
Mm-hmm.
The certification is just that extra step.
Oh, okay, yeah. And we talked to Miss April about it.
Franny, I'm gonna email you her email address in a little bit.
Okay, and I just tell her I want to take the NCCT prep.
Yeah, and it takes her I say email her about 2 weeks before you're ready. Because
Okay.
they say that's the time frame that she can schedule out from. It'll be about 2 weeks from when you contact her. But I will say this too,
Okay.
Franny is super, super busy. It may take her 2 to 3 days to respond once you email her.
Okay.
So just bear with her, she will get back with you. And if 2 or
Okay.
3 days goes by and she doesn't, let me know so I can email her, okay?
Okay, and also, with my resume, I wanted to like kind of revamp it and get help with that, so I can start applying for positions in my field.
Yes. Do you know who your career services advisor is?
No,
All right, I will email career services.
I think it was the guy, but
He's
not
gone.
there anymore.
Yeah, he's
Yeah.
gone. All right, so I will email career services and have them reach out to you. Let them know you're going to be
Thank
finishing
you.
next week and you're ready to get the ball rolling.
Yes, ma'am. And send me the links to your Zoom so I could pop in. I'm gonna
I'm
miss
not kicking
y'all.
you off a remind, girl. I'm not
Thank
kicking
you.
off. So check your remind.
All right.
All right, talk to you later.
Bye bye.
Bye.